his name to the speaker session today. Thank you so much for the session, and please continue. Over to you.
Good morning, everybody. It's very happy, feels very happy to meet you all on a Sunday morning. And thank you for the kindest introduction, Dr. Manasa, as I came to know much more better about myself today. Thank you. So without much delay, I think we should go to the session. Okay, so please allow me to share the screen.
Sure, sir.
So are you able to see my slide, PowerPoint slide?
Yes,
Dr. Suresh, yes.
Okay, so we shall start. So today's topic, I should really thank Dr. Manik Vasam, a good friend of mine, my classmate. More than a dentist, he is becoming a big entrepreneur today. So very enthusiastic and dynamic person. For choosing this topic, it's a very important topic for any general dental practitioner because more than any other dental treatments impacted wisdom tooth and its management becomes a very big priority today in our clinical practice. So the aim of this presentation is to tell you how we are going to look at the impacted wisdom teeth from tomorrow. Till today, your perspective may be different, but how are you going to see it from tomorrow? And how are you going to diagnose, classify the severity of impaction, and then how to decide whether you are going to handle that particular impaction or you're going to give it to your consultant oral and maxillofacial surgeon. So that is the whole idea of this particular topic, and it is going to take about an hour or so to complete this presentation, followed by discussions. We also have that Q&A in this Zoom meeting. So you have a small tab called Q&A. So if you have any queries while I'm talking, you can post your queries in the Q&A session so that we can discuss about it later after I finish the presentation. So impacted teeth. So by definition, the impacted tooth is a tooth that is positioned against another tooth, bone, or soft tissue so that it is unlikely to fully erupt through the gingiva to reach its normal position in the mouth. This definition is given by Archer, the pioneer of oral surgery globally, and this is the most apt definition you can see in any of the textbooks. So it can be caused by tooth, bone, or soft tissue. Okay? That is impacted tooth. So it is time to differentiate between an impacted tooth and an unerupted tooth. If you see this diagram, if you look at the wisdom teeth, the lower wisdom teeth on either side, they are not as an impacted tooth, you should only call it as an unerupted tooth. Okay, so unerupted tooth is a tooth that has not come out to the level of the mucosa, but the chronological age is not attained for that particular tooth to erupt. So that's the difference between an impacted tooth and unerupted tooth. So always in your prescription or your referral letters, you mention it as an unerupted tooth if you find this problem in younger group of generation people, or impacted tooth if it is going to be chronologically, if the patient is more than 18 years and the tooth is still not erupted, you can address it as an impacted tooth. So basic difference we all should know. Right. So let's look at the incidence. Which teeth are more prone to get impacted? The as you are all practitioners, isn't it? So you will all daily see impacted teeth. The commonest tooth which gets impacted is the lower third molar, followed by the upper third molar, and by the upper canines, lower canines, and lower premolars. These in this order they get impacted. Incidence wise, the lower third is the maximum impacted teeth you will ever see in your practice. So that is why we are going to discuss more about the impacted lower third molars, which are known as wisdom tooth. So at this juncture, I want to ask you, you know why it is called a wisdom tooth? Because the patients sometimes can ask you why you call it as wisdom tooth. Does it have a direct connection to the wisdom or not? So a very interesting thing. It is called a wisdom tooth because the age of eruption of this particular molars, third molars, is around 18 years or the range of 18 to 25 years. When a person goes to the college, university, and attains a degree, so the time is synchronizing. That is the time of getting degree or wisdom or the tooth eruption, lower third molar eruption are occurring at the same time. So that is why they are called wisdom teeth. Otherwise, it does not have any role to do with the wisdom. So sometimes I see patients asking me if I get my wisdom tooth removed, will my wisdom also will go? So it's quite common. Like I hear this question from the patients. Looks funny, but it is seriously asked from some of the patients. So wisdom tooth is called wisdom tooth because of the age of eruption. Then what causes impacted tooth? Again, the patients will keep asking you many questions before you advise or do the impacted tooth removal. Why I have impacted tooth and my neighbor does not have it, or my wife does not have it, my father did not have it. So to know about the causes, let's divide them into systemic and local causes. Among the systemic causes, we have three theories which will explain the reason for tooth impaction. First one is called a phylogenetic theory. Second one is called a Mendelian theory. Finally, the hormone deficiency, especially the thyroid hormone deficiency. The hypothyroidism can cause slow eruption or slow development of the entire stature of the patient. So that leads to impacted tooth also. So let's see more about phylogenetic and Mendelian later. Before that, yeah, okay. So this is the picture which will explain you what is phylogenetic theory that explains the impacted teeth. Okay. So the food type of food what we take is becoming softer and softer day by day. We used to have very fibrous food those days, especially our fathers, grandfathers. They used to take very fibrous, chewy food, thereby giving more work to the masticatory muscles. You know, in a way, the masticatory muscles are attached to the mandible and the maxilla. So when you eat with more masticatory forces, there is a functional stimulation to the underlying bone, leading to more growth, or the bones are actually sized enough to accommodate all the teeth. But when you start taking softer diet like these burgers, these French fries kind of thing, and when you don't eat anything fibrous, there is no activation of the muscles. This leads to less functional stimulation of the jawbone, leading to gradual reduction in the size of the bone development. So the bone has to be large enough to accommodate all the teeth. So when the jaw size is smaller, the tooth size does not change. So what happens is the last tooth which gets into the mouth is going to get trapped inside or get impacted. So this is explained by a theory called phylogenetic theory. This is actually a hypothesis, but we find this true because you know what is the type of food we are taking today. All your children want to take only pizza and burger, and they don't like to eat greens or vegetables nowadays. So this will lead to more and more problems in the future. Impacted tooth is going to be even more common. This is why you have to explain the patients why it is not there in your it was not very common in your parents and grandparents, but why do you have in your generation? Okay. The second theory that explains tooth impaction is called a Mendelian theory. Mendelian theory is based on genetic explanation. Okay, so genetic theory, for example, if an individual has a uh, dad who has got a smaller body size, or mother with a larger body size, as you see in this picture, or vice versa also, dad may be bigger and mom may be smaller. So if you or any individual is going to inherit the genetic signals for the jaw development from the small statured parent, and the tooth development from the genetic signals from the other parent who is more fatty, the jaw size is going to be smaller, the tooth is going to be in normal size. So the smaller jaw finds it difficult to accommodate all the teeth, finally resulting in impacted third molars. Okay, so this is explained by the Mendelian theory. So the moment you say it is genetic to the patient, they will ask, my father did not have this problem. So you have to explain, you can't explain all these things in detail to the patient, and it is not necessary also. Genetic, in the sense, you don't have to be inheriting directly from one of your parent. It is actually a mixture of signals coming from your father and mother, and from your grandparents also. So there is a mismatch between the size of the jaw and the tooth genetically, and so there is a problem leading to impaction of the tooth. That explains through the Mendelian theory. Then, of course, we have local causes that can be related to the tooth, bone, or soft tissue. When you say tooth related local cause, the tooth can have abnormal configurations, like you can see hypersymantosed tooth, bulbous root, or dilacerated, very abnormally curved root. All these things can cause problem in eruption of the tooth, leading to impaction, or it could be problem from the bone itself. The bone can have more sclerosis, or the bone may not be very elastic. So due to some systemic factors again. So like osteogenesis imperfecta, all these things can lead to sclerosing or more hardening of the bone. Then the tooth finds difficult to penetrate the bone and come out. So that's bone related issues. And soft tissue related issues, where you have the surface mucosa, oral mucosa, which is fibrosed. So in that situation also, it might penetrate the bone, but it may not be able to penetrate the mucosa, fibrosed mucosa, leading to impaction. Okay, so when you start dealing impacted teeth in your clinic, especially the lower third molars, you need to classify them, which will give you a rough idea how difficult or how easy it is going to be, and whether you can perform it without any issue. Okay, for that we need a classification. The very popular classification everybody studies in the undergraduation itself is called Winter's classification, where you have wisdom teeth or the lower third molars, which are classified as vertical, mesioangular, horizontal, distoangular. All of these can be either buccoverted or lingoverted also. So basically we have these four categories of impacted wisdom tooth: mesioangular, vertical, horizontal, or distoangular. So many a times we find when we look at the X-ray and clinical scenario, we get confused between the nomenclature, whether it is a mesioangular or a distoangular. Okay, so how to differentiate whether it is mesioangular and horizontal is, if you draw a vertical line along the long axis of the second molar, and draw one more long axis along the third molar, impacted third molar, if the intersection is less than 35 degrees, you call it as mesioangular impaction. If the intersection, the angle is more than 35 degrees, then you should mention it as horizontal. This is a very clear explanation given in the textbooks. It's not my classification. It's already there in the textbook. So we don't have to get confused between mesioangular and horizontal. And then the other category where the real confusion exists is between the vertical and distoangular. Both will look alike in the radiographs. If you look at them, they will be straight. Okay, so you can either say it is vertical or distoangular. Both will look very, very similar. How to differentiate between vertical and distoangular is to look at the amount of interdental space or the interdental bone between the 7 and 8 here, or between 6 and between 6 and 7 here. So if the interdental bone is the same here and here, then you call it as a vertical impaction. But if the interdental space between 7 and 8 is lesser than the interdental space between 6 and 7, then you call it as a distoangular impaction. A very simple point which will clearly tell you it is vertically impacted or distoangularly impacted. This point is very important because you need to assess this well before you diagnose and execute the procedure, because vertical impactions are very easy to remove, whereas distoangulars are the very difficult impactions to remove. Remember, the x-ray will show you as if it is vertical, and it's going to be, you will think it is going to be easy, but many a times we struggle when we deal the distoangular impactions. Even in oral surgeons, after a lot of experience, when we deal with distoangular impactions, it is very difficult to remove. So do not underestimate this scenario. You should actually call a consultant to do this procedure. The difficulty here is because the bone covering the distal part. So when you look at from the anterior part of the mouth, what you will see is only the occlusal surface. All these will be hidden under the tooth. When you use a motor on the burr, it will cut like this. So you won't be able to remove this part of the bone, and there will be a continuous resistance. That is why we find it difficult to remove the distoangular tooth. So if somebody is experienced in impaction, they will also slice the tooth here so that they can remove this part of the bone. Then it will come out more easily. Okay, so differentiating between mesioangular and horizontal, more importantly, differentiating between vertical and distoangular is very important to be seen or studied. Okay, we also have another way of classifying it, which is known as Pell and Gregory classification. Theoretically, it is very good. Practically also it is useful. What we commonly use is this Winters classification, which we just now discussed, but this also has a very useful role. In Pell and Gregory classification, we have two categories. Number one is called a class, second one is called division. So in the class category, there is 1, 2 and 3. The class explains the amount of tooth that is existing behind the distal surface of second molar and the mesiodistal width of the impacted third molar. Okay, so if you look at an x-ray, if you find there is more space distal to the second molar and between the anterior border of the ramus, the space is distance is more than the mesiodistal width of the impacted third molar, then you call it as a class 1 category. So logically it is going to be more simple when you try to remove it, because you have a lot of space and the elevation process also is going to be easier. That's why class 1 is going to be simple for you. What is class 2? Little more difficult. The space between second molar and the anterior part of the ramus is equal to the mesiodistal width of the third molar. So this is going to be a little more difficult to remove compared to the class 1 cases. The more severe cases is the class 3 cases, where the entire tooth or the impacted tooth, lower third molar, is going to be present inside the ramus. You see a lot of bone here around, all around the tooth. So this category or the class 3 category is going to be very difficult to remove. So this we have to understand. So always go through the x-ray very carefully. Don't be in a hurry to decide whether it is class 1, class 2 or class 3. Analyze properly, then you decide the treatment for that particular patient. So another category in Pell and Gregory is division, as I told you. So this is mentioned as position, okay, position A, B and C. Rather than going through the text and write-ups, we will go to the diagram which will explain it better. Here, the position explains the occlusal surface of the impacted tooth in relation to the occlusal surface of the other molars. In position A, the occlusal surface is in level with the occlusal surface of the other teeth. That means it's almost fully erupted. Only thing, the distal part is buried inside the bone. Take the division B, it is slightly lower than that. It does not come to the level of occlusal surface of the other tooth, but it is little bit higher than the CE junctions of the other molars. Okay, somewhere in between. That is position B. Then you have position C, where it is very deeply seated. The occlusal surface of the impacted tooth is going to be below the CEJ of the adjacent teeth. This is the position A, B and C. So any combination is possible. Class 1, you might see a class 1 position A tooth, or class 1 position B, class 1 position C, class 2 division A, class 2 division B, class 2 deficiency. Likewise, in class 3 also ABC or any combination is possible. Analyze them properly. But we are studying theoretically all the classifications, but nature has its own classification. Sometimes don't get surprised when you see teeth like that. So sometimes you will get conditions like this. This is actually a class 3 position C according to the Pell and Gregory, but it's two very severe case. You can see the root is actually penetrating the lower border and is even palpable clinically. So this also is possible. And sometimes there is more confusion when multiple teeth are impacted. You can see all the molars are impacted. This is all mostly related to hormonal issues. So you have first, second or third molar, so you really don't know what classification it will come under. So this is for complicated cases, but in general what you get is a isolated impacted lower molar tooth which can be easily classified according to the Winters or according to the Pell and Gregory. There is also, so the teeth can be seen like this. You can see a bullseye appearance of the lower third molar, where you see the crown is here, the root is up. Now occlusal surface of the crown, if you cannot relate it to the tooth because the root is on the higher level. So this is all very confusing, but luckily these conditions are rare, so we don't have to worry about these difficult situations. So we are worried more about the regular standard cases which will be reporting to your clinical practice. So, what are the indications for removal of the third molars? It has become a very routine practice for everybody to advise surgical removal of impacted third molars routinely. Okay, because there are some issues caused by the impacted tooth. So, what are they? What are the indications? Let's see one by one. Number one, the very common cause that indicates removal of impacted tooth to a third molar is the pericorneal inflammation. You can see in this picture how badly it is inflamed all around the impacted third molar. In this case, the patients also will ask you like, can you leave it for some more time, and it can actually erupt on its own. So it's a good question. The clinical indication for removal based on pericoronitis is, if you are seeing a patient with this like this, you ask the patient, is this the first time you are getting such a problem, pericoronitis problem? If it is the first time, probably we can still think of giving only medicines and then waiting for some more time. But if it is a persistent pericoronitis, if the patient says, I have got it for 1 or 2 months continuously, nothing is actually treating it properly. Not medicines, not saline goggling, nothing is helping to relieve the pain and in the infection. So persistent infection or recurrent infections. The doctor prescribed me medicines. I took it for 3 5 days. It became better. Now after 2 months, it has recurred once again. So pericoronitis persisting or recurrence is an indication for impacted third molar removal. Then again, very common scenario with impacted lower tooth third molar is dental caries. You all see it very commonly. I don't have to explain. It's a clean cut indication. Third indication is again the pathology which can be associated with impacted lower third molars. The cystic lesions and benign tumors like dentigerous cyst, odontogenic keratosis, cystic ameloblastoma, all can develop from the follicle of the impacted tooth. So there is a potential for developing pathology from the impacted tooth. So when you take an X-ray, when you see such a big radiolucency associated with impacted teeth, we have no option other than advising them to undergo cyst enucleation along with the removal of the impacted teeth. Okay, there is no other alternative treatment available. Then it can also cause damage to the adjacent tooth roots. The second molar the roots can undergo resorption due to pressure of the impacted tooth on it. So this is also an indication because this tooth is not going to work well. So we, at least by removing this, we can save the second molar. So that is also an indication for removing the wisdom tooth. And then one other situation is causing anterior teeth imbrication, otherwise anterior lower anterior crowding. Suddenly the patient will find there is some crowding of the lower anterior teeth. Initially it used to be very nice. At the age of around 19-20 years, when I suddenly saw the teeth were going front and back, and there is a malalignment of the lower anterior teeth alone. So patients will be a little bit confused why this happened. I didn't do anything. So this is one of the rare indications. It can be caused by your wisdom teeth. Like when the wisdom tooth or the lower third molar is trying to come out, erupt into the oral cavity, when it does not find good space, it will act the ramus as the fulcrum and it will try to push all the other teeth with the forward direction. So at the time of eruption, you will suddenly see there is lower anterior crowding. This is not a very common scenario, but this is possible. So when your patient suddenly says, I have a crowding in the lower anterior, which developed recently, all these days it was fine, sudden development, and the patient is in the young age category between 18 to 25 years, please take an X-ray radiograph and check the impacted teeth. So this also is an indication for removal. If you identify this problem early and you remove the wisdom tooth or the impacted tooth, erupting tooth, then all the others will get relieved of the pressure. The malocclusion can get settled by itself if it is detected in the early stage. Right, clinically, all these problems, what they cause is pain, swelling, trismus, partially erupted third molars will be seen in the X-ray, and in few cases you will also see anterior imbrication, especially in the anterior, the lower teeth. So how to clinically, consolidate your clinical diagnosis. I know I have seen a tooth which is partially erupted in the mouth. Patient has pericorneal inflammation or decay in that particular tooth. But I need to show the patient it is coming in a wrong direction. That is why all this problem is happening. So to consolidate my diagnosis clinically, I need to send them for investigations like radiographs. You don't need to have a very complicated investigation tools. Just the plain, the two-dimensional X-rays will do. It can be either intraoral like IOPA or occlusal, or we can also take OPG, extraoral X-ray. These can show us better pictures. If you ask me which is the best X-ray for assessing the impacted lower third molars, all the textbooks also say the IOPA X-ray is the best X-ray to diagnose, provided we take it at the right angulation. If you look at this IOPA radiograph, what tells you this is an ideal radiograph? When you don't see any overlapping of the enamel between first and second molar here, that means the angulation of the X-ray beam is correct, and whatever you are going to assess regarding the third molar is going to be perfect. So this is a perfect X-ray. It is a good X-ray. There are only two issues. First issue is difficulty in accommodating the sensor or the X-ray film inside the mouth. The patients may not be very comfortable, and obtaining the right angulation of the X-ray tube also may be difficult. Second difficulty in IO X-rays are relating the tooth to the inferior alveolar canal. So sometimes it's going to be difficult. You don't see the inferior, even in this X-ray you see little bit of the inferior alveolar canal here, but we don't see it perfectly. So only in OPGs you can see this. So you always start with IOPA X-ray to analyze the position of the third molar, or if it is going to be difficult, if you don't see the teeth or the canal fully, then you go for an OPG. So what are the points to be looked at in radiographic assessment? So there are certain key features you should analyze. One is called axis, second is position of the third molar, shape of the crown of the third molar, root pattern of the third molar and the second molar, and what is the texture of the bone, and what is the relationship of the inferior alveolar canal to the impacted lower third molar. All these points to be gathered from the X-ray assessment. Okay, so we'll see one by one in a little bit elaborated way. First one is to axis assessment. So if you see the anterior border of the ramus, as you see in the left hand side picture, it is more vertical. Okay, so the vertically placed ramus means most of the tooth is inside the ramus, and so we will have to remove lot of external oblique ridge and anterior border of the ramus here, so which is a difficult process clinically. So vertically oriented ramus, anterior border of the ramus cases will be difficult. If you look at the other X-ray on the right hand side, you see the external oblique ridge or the anterior border of the ramus, which is more horizontal in direction. That means you have more space and clearance on top of the impacted lower third molar crown. So this case, it may be visualization is better. The bone removal, what you require will be limited. So it's going to be an easier case. So this tells you what is access and how it is seen from the radiograph. Next, the position and depth of the impaction is based upon the Winters classification and Pell and Gregory classification. If you do one of these classification, especially Pell and Gregory, we are going to know what is the amount of or the severity of the impaction and how difficult it is going to be. Then you are looking at the crown of the tooth. Okay, in this X-ray on the left hand side, you see the crown is a little bit smaller, but in the other radiograph on the right hand side, it is a very large crown, so it will be actually well locked within the bone. It's going to be difficult. All these radiographic examination is going to tell you whether the process is going to be easy or more difficult. Okay, then the root of the third molar as well as the second molar. So the X-ray on top, OPG on top shows it's more of a conical pattern root. So this will be easier to remove. Whereas in the lower OPG, you have the roots which are actually showing divergence, which will have an anchor-like effect in the bone, and so it's going to be difficult to remove without doing sectioning of tooth and all that. So conical roots are easier to be removed. The divergent roots are going to be more difficult to be removed. So I also mentioned you need to have a look at the root pattern of the second molar. Why so? If they have a divergent root, they are going to be very firm in place. When you apply pressure, especially when there is a small tooth lock like this tooth or this tooth, it will not get disturbed. Whereas if the second molar has a conical root, and if you are going to apply more pressure while you elevate the third molar, that can cause dislodgement of the second molar also. That is why you should study the root pattern of the second molar also. So conical roots easier to remove, bifurcated it's going to be difficult to remove. If the root shows any abnormality like hypercementosis or dilaceration, it is going to be even more difficult to be removed. And how do you see the texture of the bone? Texture of the bone is actually very difficult to study from the two-dimensional X-rays, but you can have a rough orientation whether it is going to be a soft bone or a hard bone, because soft bone means easier removal, hard bone is going to be tough to remove. So look at the left side OPG. So normally, how does the bone appear in the radiograph? You will have white striae or lines which are the trabeculae, which are called the trabeculae, which is the hard part of the bone. In between the white lines, you have dark spots, which are more soft or marrow bone, cancellous bone, which is going to show the easier or the softer nature of the bone. So normally there is a balance between trabeculae and intertrabecular medullary bone. So this X-ray shows on the left hand side, this shows there is a balance between trabeculae and the marrow spaces here. You can see both trabeculae and in between the marrow spaces. So this is a normal kind of bone which will be easy to remove. But on the right hand side, this patient must be an aged patient. You can see very limited medullary spaces, but there is more of cortical nature. These kind of situations, if you want to remove this tooth, the bone is going to offer more resistance. So, and it is going to be more tough to remove this kind of tooth. So, it is only a rough orientation through the two-dimensional X-rays. It's very difficult to assess from the two-dimensional X-ray. Just for completion's sake, we also have a look at the bone. Okay. More important in lower third molar assessment is the relationship of the impacted third molar to the inferior alveolar canal. This we miss out many times. Luckily, we live in India and we don't have much of medical legal issues. But if you live in Western countries or Europe, um, uh, developed countries, if you remove a wisdom tooth and if you cause paresthesia due to injury to the inferior alveolar nerve, it is going to become a very big problem because patients are ready to sue you immediately. So be little careful to study the inferior alveolar canal relationship. I think by now you would have had some experience about this. Causing paresthesia is very difficult to manage. more common complication, but very difficult to manage because nobody knows how much severity or how much severely the nerve is damaged, and nobody knows when is it going to recover. But the patient will keep coming to you every week, once in 2 weeks, to see you, telling that it is still numb and we don't have any recovery. So study that. So what are the expected relationships between the impacted wisdom tooth, lower third molar, and the IAN canal, inferior alveolar nerve canal is superimposition. This is all can be studied better in the OPG only, not in IOPA X-ray. Okay, remember. So if you think the case is going to be a difficult case, do not hesitate to go for an OPG. Okay. So the relationship can be superimposition or apical notching or grooving or perforation. These can be the relation. Let's see one by one what they are. This is the normal relationship, what actually is expected. You have the root and the crown here, which is slightly separated from the inferior alveolar canal. You know, the inferior alveolar canal is represented by two parallel radio-opaque lines. Okay, so the root ends here, the canal starts here down. So there is a small separation in between. This is the normal relationship what we expect, but it does not be there all the time. So sometimes we have more closer relationships. For example, this is called a IAN, inferior alveolar nerve superimposition. So if you take an X-ray like this, clinically the inferior alveolar canal shadow will be overlapping the root of the third molar. So in this case, it may not be very close. The tooth may be placed lingually or buccally to the inferior alveolar canal because it's a two-dimensional X-ray. There is only overlapping, and so you see in this X-ray as if it is passing over the root. Okay, so how to differentiate? So if you see this kind of picture in the OPG, you have to study the shadow of the tooth and the canal separately. So look at the root shadow, follow the root shadow. There won't be any interruption in the root shadow, and then you trace the inferior alveolar canal shadows, both the upper line and the lower line. Now you will see there is no disruption in the canal shadow also. Like that in the X-ray, if I follow the root outline, there is no interruption, there is no radiolucency. It's continuously homogeneously radio opaque. Okay, like that, when I look at the inferior alveolar nerve shadow also, you see the line which is intact, the lower line also is intact, there is no interruption. That means it is actually superimposition. There is not much of close proximity of the nerve to the tooth. So in these cases we are very safe. You can remove the tooth without any problem, without causing damage to the inferior alveolar nerve. That is superimposition. What is the next relationship that is possible, which is this is known as an apical notching. So when the third molar is deep-seated, position B or C, it can go down up to the canal. It can just impinge on the canal. In this situation, you will be able to follow the root shadow continuously without any disruption. But if you follow the shades of radiopaque lines of the IAN canal, the upper line will be lost its continuity in the root apex region, whereas the lower will be still continuing. Here you can see the root shadow is not altered. In the upper line of the IAN canal, it is radio opaque up to this point, and then it runs here. There is no radio opaqueness which can be appreciated in relation to the apex, but you can see the lower line which is continuously running. So this is called an apical notching, meaning the root apex is sitting right on the nerve. So in this situation, you have to tell the patient we have a small possibility of causing paresthesia due to injury of the inferior alveolar nerve. So warn them before, otherwise if it is caused without explanation, after the surgery they will come and report you did the extraction and now lip is numb, it is not recovering. So this is to be picked up from the X-ray and to be explained to the patient before the procedure, not after the procedure. So always evaluate the IAN canal. So to avoid injury to the nerve in this situation also, if you remove more bone around the tooth, give gentle pressure to elevate it, then probably we can avoid injury to the inferior alveolar nerve. Next relationship is called a grooving effect. Here it is almost like the superimposition what we just saw the first slide. So again here also you will see the shadow overlapping shadow of the tooth and the inferior alveolar canal. But if you trace the tooth shadow and canal shadow, tooth shadow will be little bit less radio opaque in the region where it is crossed by the inferior alveolar canal. You can see the radiolucency where the nerve is crossing the roots. Rest everywhere it is going to be radio opaque. Look at the X-ray example. So you have radio opaqueness of the root here, radio opaqueness of the root here. But where the line is crossing, the inferior alveolar nerve is crossing, the root shows a kind of radiolucency. That means it is not only superimposition, the nerve is actually very close to the root, in fact grooving the root. So in this kind of situations, we have lot of possibility for causing paresthesia to the patient. So it is very difficult to manage the paresthesia if it has been caused. So in this case also explain the patient there is a possibility, there may be some extended numbness of the lip after the procedure. So explain them and then do it, they will understand. And then finally, there is a very tough situation which is called a perforation, which we see it very rarely. I have never seen. I have been told by my friends they have encountered such a situation, but very rare, very rare. That is, the nerve will enter on the distal side of the tooth and it will perforate the root and will exit through the mesial side of the root. It will continue as IAN canal. Okay, you can see after extraction there is a perforated part of the root which is caused by the inferior alveolar canal. So these situations can be in the X-ray. It can be assessed by something called an hourglass appearance. It's called hourglass because you have the parallel lines which are intact here, parallel lines which are intact here, but here there is a narrowing where it is perforating the tooth. So it's called an hourglass shape. Very difficult to pick up from the X-rays, but it's a very difficult scenario. In this situation, preserving the nerve is actually extremely difficult. So this kind of situations can cause paresthesia permanently in almost all the cases. What else you see in the X-ray? So there is a simple way of assessing the difficulty index, how difficult it is going to be during removal. One is known as war lines. War lines is named because of the colors which they use to draw these lines. White line, amber line, and red line. White, amber, red. So that's why they are known as war lines.
You going meeting அப்பாவோட பைக் சாவி மாடி வருது இருக்கும்போது
Okay.
இந்த மொபைல் மேல இருக்கும் சரி
Somebody has to mute.
அத்தை சொல்லி தராத நிமிஷம்
Yeah, somebody has to mute. I can hear more voices. Somebody has not muted and they are talking. Okay, fine. Right. So war lines, as I said, it's named because of the color of the lines. So let's look at the first line, W line or the white line. White line is drawn in line with the occlusal surface of the posterior teeth, white line. Then you have the amber line. Amber line is drawn from the curvature of the anterior border of the ramus connecting to the interdental bone between 6 and 7, not 7 and 8, 6 and 7. Okay, so many times we do a mistake. We draw a line like this connecting the interdental space between 7 and 8. It's not correct. It should be connecting the interdental space between the 6 and 7. So what does it indicate? Whatever is below this amber line is going to be bone. Whatever is above is the structures that are seen clinically are only covered by the mucosa. So for example, in this picture itself, I have drawn the amber line. So no part of the tooth is going to be visible inside the mouth. Only after you elevate the flap, you will be able to appreciate the tooth which is here below the amber line. So what is the R line or the red line? Red line is a perpendicular line that is drawn from the amber line to the point of application. So we'll talk about point of application a little more later. So this is the perpendicular line. You know, we apply the elevator here on the mesial surface of the impacted tooth and then we are going to elevate it. So this line will tell you the amount of difficulty that is expected during your bone removal and the tooth elevation. Okay, so if the line is shorter, that means there is little bone covering the tooth. It's going to be an easier tooth. The longer the line, you can actually measure it through the X-ray. If it is more than 8 or 10 millimeter, then that is a case to be done under general anesthesia, not under local anesthesia. So the difficulty index can be easily analyzed from war line assessment. What else comes for help for assessing the difficulty index? We also have something called an Warfi assessment. Warfi, again, each alphabet in the name Warfi says a different thing. W for Winters classification, H for height of mandible, angulation, root pattern, follicular space, and then exit pathway. So you have to see all these things in the X-ray, and then you have to score it ranging from 0 to 5. So Winters classification, if it is vertical, you name it as 1, mesioangular 2, horizontal 3, distal angular 4. Like that, you have to score each on every point, and then you are going to add all the total. If the number is very high, that means the tooth is very difficult to be removed. Less the number, easier the removal. That is explained by the Warfi assessment. So now comes an important question. So having studied so much, now who is going to remove the tooth, whether the general dental practitioner or the maxillofacial surgeon? It's a very important decision to be made in our clinical practice so that we don't struggle much. So easier cases like vertical or mesioangular class 1 and position A or B can be removed by general dental practitioners. Many people hesitate to remove impacted lower tooth because they really don't know whether they are eligible to remove or allowed to remove legally or not. See, your degree, what is given to is Bachelor of Dental Surgery. So you are basically a surgeon. In your curriculum, it is included. In your practical exposure, you have assisted cases. In your internship, you have done some of the cases like transalveolar and simple impaction cases. So even if you are an undergraduate student, you are eligible legally to do impaction cases, even if you are a general dental practitioner. But do not attempt all the cases. If you see more difficulty in the radiograph, you better call your consultant to do the procedure. Okay, right. Generally, the points which will be very which will indicate removal by you is when the patient is not very apprehensive, cooperative patient with a good mouth opening, and in the radiograph it is only vertical or mesioangular, but it is not having class 3 or position C, and then you can do it yourself. If you are doing it, please study the inferior alveolar nerve canal relationship well, and then you start doing it yourself. So this picture explains overzealous attempting of distangular impactions, over confidence can lead to disappointments. So do not try to remove disto-angular severe cases thinking that it's going to be easy, vertical like that and all. We will end up in disappointment, more trouble to the patient. So we will leave it in halfway, then again you have to call the consultant. So read it properly, read the X-ray properly, assess the difficulty as such, and then you decide whether you are going to do it or you are going to call a consultant. So if you have decided to do it yourself, it is an easy case. Give proper preoperative instructions, that is what will be the procedure, how much post-op swellings is expected, what are the medications will be prescribing, how long rest he will need, and when he can get back to work. All these things you have to explain well in advance, and then be little careful in choosing the drugs. People think steroids are actually very bad. Steroids are very bad if it is given in high dose and for longer duration, but short low dose steroids are not very harming. So I usually do impactions along with the antibiotics. Also I combine steroids like prednisolone in low doses, 10 milligram or 5 milligram, 2 times or 3 times a day, depending upon the difficulty, how long I have taken, is actually going to help reduce the swelling quite a bit. So your patients are going to be really happy if you have done a procedure and there is not much of swelling. They are able to speak, eat, and go to the office sooner. They will be very happy. So do not hesitate to include low dose steroids for short term therapy. I usually recommend only 3 to 4 days because according to the textbook, the surgical edema stays only for 2 days, that is 48 hours. From day 3 onwards, it will start decreasing. So if I cover the inflammatory edema caused by the surgical procedure for 2 to 3 days, it is more than enough. So I usually recommend um, Visolone or the prednisolone 10 milligram twice a day for 3 to 4 days. That's more than enough. That makes the patient extremely comfortable. and also briefly explained about possible complications that he has studied from the X-ray well before the appointment. They do not explain any complications that are expected during the day of the surgery. Okay, if you tell paresthesia possibility, there is a possibility for fracture of the mandible on the day of appointment, the patient will panic. So do not do that. Please explain everything in prior. Okay. So when you decided to do the procedure, what are the options? We have local anesthesia, intravenous sedation combined with the local anesthesia, or it can be general anesthesia. I am very sure you are not going to be very comfortable doing it under general anesthesia because you are not trained. It is okay, but we are not going to select cases to be done under general anesthesia. We are only going to select cases which can be done under local anesthesia or under intravenous sedation. So these two are very good. Local anesthesia for if I see only one tooth has to be removed, that also is very easy. I prefer local anesthesia. Sometimes it's a more difficult case, going to take more time. And simultaneously, if I am planning to remove both the wisdom teeth, or if I find the patient to be very anxious, I will prefer to do it under IV sedation. The indication for general anesthesia is different. As I told you, in VAR lines, if the red line is going to exceed 8 to 10 millimeters in length, or if it is very closely associated with the inferior alveolar canal, yes, we have to choose general anesthesia, which the pains will be taken by the consultant. You don't have to be worried. Then incisions. So you're all regularly practicing impacted tooth removal, I'm sure. So there are three type of incisions which are available. One is called an envelope incision. Next is warts incision and modified warts incision. Generally, what we choose to place is called a warts incision, which I will show you through the X-rays, through the diagrams. This is the first incision or the envelope incision where we do not have any vertical releasing incisions. You can see all the incision is running horizontally here. So the first part of the incision is made along the gingival crevices starting from mesial to first or second molar, and then it will run vertically along the gingival crevice. When you reach the impacted third molar region, you take the incision, continue the incision distally and slightly buccally, disto-buccal direction. Never go straight or lingually. That's a very dangerous thing to do because you have the lingual nerve that is present medial to the mandible. So if you take the incision directly up or lingually, then we have all possibility to damage the lingual nerve. So take the distal incision always towards the external oblique ridge, that is distobuccally. So this is called an envelope incision because we have not made any vertical releasing incision. Okay, so the next picture will explain the warts incision. Okay, here again we have made an incision distobuccally, then we have gone through the gingival sulcus of the first molar. We have made a releasing incision, vertical releasing incision, that is mesial to the second molar. Okay, so the same releasing incision can also be made here, that is mesial to the third molar. So if you make this incision mesial to the third molar, you call it as warts incision. But if you extend it till the mesial aspect of the second molar and then release it, it's called modified warts incision. So what is the difference? If your case is a simple case, a very simple mesioangular case, which you expect it to be very easy, you should prefer to use warts incision like this. Okay, make an incision like this, end it here itself. And this releasing incision, remember, it should cross the mucogingival junction. If you don't cross the mucogingival junction, the pliability of the flap is not going to be there. So you have to go to the moving or mobile mucosa and you should cross the mucogingival junction. Okay, so if I have an horizontal impaction, I want more exposure, then I will take the incision along the gingival crevice of the second molar also, and I will give a vertical releasing incision that is mesial to the second molar. So this is called a modified warts incision. So you have three options for incisions. Generally that envelope incision what we discussed first is more than enough to do all the cases, but if you are a general practitioner or beginner, I would recommend to go for a vertical releasing incision so that holding the flap, visibility, removal of the tooth, everything is going to be easier if you make a warts incision or a modified warts incision depending upon the severity of the case. Next, once you have made the incision, you have opened up a flap, isn't it? Now, what is next in impaction? You all know you have to remove bone to relieve the mechanical obstruction so that we can elevate or remove the impacted tooth. Okay, bone removal, we have certain tools that can be used. There are three categories. One is your chisel and mallet, second is your micromotor, third is your piezo surgical units, which are very recent development. So when I was a student, when we were taught impactions, we used to have chisels and mallet to remove the bone, sounding very cruel, but some of the peripheral areas still they practice this chisels and mallets. They are effective tools actually. When you use chisel and mallet, it causes less postoperative edema and pain because there are clean cuts and the bone is removed in large chunks. So chisel and mallet is actually good in a way to the patient, but when you do the procedure, it is extremely uncomfortable to the patient. Banging on the chisel with your mallet is extremely painful, and people are more demanding nowadays. They don't accept this kind of procedure. So I will strongly disagree using chisel and mallet today to remove impactions, because we are having better gadgets today to smoothly remove the impacted wisdom tooth. The second category, as I explained, is micromotors or surgical motors, where you have the motor and there is a straight handpiece that can be used. Remember, the counter angle handpiece does not have much role because it does not have adequate torque. So always use micromotor with straight handpiece with surgical bursts. Okay. So the speed what is recommended in micromotors are between 40,000 to 60,000 RPM. Okay. You all know in the aerotest the RPM is in lakhs, 2 lakhs minimum RPM is used in aerotest, but in micromotors or surgical micromotors it's only 40 to 60,000 RPM. This is the piezo surgical unit. We have a lot of companies which have this. NSK has, Woodpecker, Mectron, so many are there today. So this is how it will look. It is almost like your regular scaling machine. It will have a handpiece, a saline attached unit, piece of surgical unit. So this tip, when you place on the bone and activate the tool, the handpiece, it will remove the bone gently, and there is no vibration like how it is caused in micromotor. So the patients are very comfortable. It is almost like having a scaling done for them. So they are very comfortable. This machine is a little bit expensive, but it's very good machine. Another very good advantage of piezo surgical units are they do not damage the soft tissue. Even by mistake, if you touch this with the soft tissues like lingual soft tissues, lingual nerve, inferior nerve, or buccal flap, it will not damage, it will not cut the soft tissues. Whereas if you touch the soft tissues with their surgical burst, it will definitely cause damage to those structures. So that's the advantage of using piezo surgery. The disadvantage of piezo surgery is the cost and the time taken. Because it's a slow cutting machine, it is going to take definitely almost double the time like your surgical motor. So initially you will find it very frustrating to use this machine. Okay, we have a very big doubt. I told you aerotor rotates in a very high speed in lakhs of RPM, but this is the right hand side picture shows your surgical burr, which is operated at a lower speed, 40 to 60,000 RPM. So why don't we use aerotor instead of surgical burrs? So before going into that particular point, we should know what is the difference of using the aerotor burr and the surgical burrs. So you all know aerotor burrs. It's nothing but the burr is coated with diamond tips. Okay, diamond particles are coating this burr. So when you use this burr on any hot substance, it is only going to abrade that part. This is how you prepare a cavity, or you do a crown preparation or bridge preparation on a tooth. So it is only abrasive action. Okay, on the tooth it is okay, but on the bone it is not okay, because the abrasive action causes more postoperative edema and the pain. Okay, whereas the surgical flutes or the surgical burrs will have a real cutting edge, which will make a clean cut on the hard substance or on the bone. There is no abrasion, it's only a cutting action, so it causes less damage to the bone or less heat generation on the bone, leading to better post-surgical outcomes. Okay, so we are not supposed to use aerotor to remove impacted or broken tooth in our clinical practice when you do a surgery because of air emphysema. The aerator has got compressed air coming out through the aerator handpiece, isn't it? So you have already raised a flap. So this compressed air, if it is going to enter in the same compressed high speed, it can enter the tissue planes causing air emphysema. That has happened in few situations. So it is not indicated for surgical cases. Never use aerator, especially if you have raised a flap already. Sometimes you will relieve the tooth lock using aerator before raising the flap. Okay, once you have raised the flap, there is no question of aerator. You cannot use it to split the tooth. You should never use it to grind the bone. Aerator is not at all indicated. For there is another reason, the water which comes out for irrigation through the handpiece is unsterile because it is filled up in the booster. It may be clean water or even RO water, that's true, but it is not a sterile water. Sterile and clean, that meaning is totally different. Whereas when we use the micromotor, your assistant will be continuously irrigating with sterile saline. So that is actually better. So aerotors are not allowed in surgeries. Next important point, we have raised a flap, we have removed the bone. Still it may be little difficult to remove the tooth because the tooth may be impinging on the second molar, which is known as a tooth lock. So when there is a tooth lock, we will have to section the tooth, which is known as odontectomy. Or if the tooth is very near to the vital structures like inferior alveolar canal, then also it is better to section the tooth into 2 or 3 fragments and you remove it so that there is not much of risk of damaging the vital structures. So odontectomy, otherwise known as tooth sectioning, is indicated in these situations. Sorry. Okay. So how to assess whether we need the tooth to be sectioned or not? So look at this picture. This is the second molar. This is the impacted third molar. So if you draw a line or a radius extending from the tip of the mesiobuccal cusp to the root apex, distal root apex, and using this as the radius, if you draw an arc with a compass, if the arc is going to run through the shadow of the second molar, that means there is a tooth lock. If this does not run along the shadow of the second molar, then there is no tooth lock. So if you find it is running through the shadow, like how it is shown in this picture, it needs to be sectioned. The third molar has to be sectioned to remove it gently without damaging the second molar. Okay, like this, you section the tooth into 2 halves, remove one by one. So there are various or 2 types of odontectomies. One is called cross section. Cross section is the right hand side picture. You do a cross section, that is, you make the crown separate and the root separate. The other one is called a longitudinal sectioning. Longitudinal sectioning is along the long axis of the impacted tooth. So you split the tooth into distal half and mesial half. The crown and root are still attached. Crown to that part of the root is still attached. Whereas here in cross section, entire crown is separated first and removed. Then we remove the root portion. Okay, so when to do a cross section, when to do a longitudinal section. So for doing it is always easier to do a longitudinal section because you imagine you are holding a straight handpiece from the anterior part of the mouth. You can only hold the burr in this direction very easily. If you want to cut in the cross section, you have to keep the handpiece vertically here where your mouth opening may not allow the upper tooth may be hitting. So doing a cross section is actually very difficult. So doing a longitudinal section is relatively easy. So people always prefer to do a longitudinal section and then remove the distal half followed by removal of the mesial half. But there are some situations which may not permit us to do longitudinal section, where when you don't have this bifurcation, when it is an conical root, there is no bifurcation, then we don't have a choice. We will have to do only cross section, remove the root, and then remove the conical fused root separately. So this is how we decide whether we are going to split the root longitudinally or by the cross section. Then point of application everybody knows. For all the teeth, the point of application is on the mesial side below the CE junction. Only difference is in the distoangular tooth. If you apply the elevator on the mesial side, it will only go still more distally and never mesially or up. So in this scenario, please try to use your elevator on the distobuccal aspect of the tooth and try to elevate. Once it is loosened, you can use a Cryas elevator in the buccal guttering, and then you can elevate the tooth. So mesial application is actually difficult to deliver the tooth in the distoangular impactions. Rest everything mesial point of application is fine. Once you have done the impaction, you should never forget to do a thorough irrigation with saline, because so when you cut the bone, you will be continuously irrigating and everything will keep coming out in the saline and in the suction tube. But there will be some part of bone dust that will enter inside the periosteum, under the periosteum, and it will collect somewhere down, deep down. And what it does is it will cause something called a periostitis. The patients will come telling that there is a hard swelling even after 2 weeks, even after 1 month, even after 2 months, which is actually caused by periostitis. With the reason is collection of bone dust under the periosteum. So you need to open up the flap very wide and then irrigate nicely. Make sure you remove all the bone dust from the surgical site. We can avoid periostitis. And then if there is any broken part of the tooth, crown or root and bone fragment, please remove them carefully, and then make sure on both sides there is no sharp bony edges. Make it smooth either with the bone ronger or a bone file or a small round burr. That also helps to smoothen the bone. So sharp margin smoothing is important before you do the suturing. Okay. Sutures, yes, we have non-absorbable, which is more commonly used. We also have absorbable sutures. This is non-absorbable is the right one for our field, because we are leaving the suture material inside the mouth, whereas there is continuous saliva around the suture material, which will also invite the food collection around the suture material. So this any non-absorbable or the silk sutures, as you all are aware, we are going to remove it after the 7th day or the 10th day. So there is no more chance for food collection or saliva collection around the incised area, so there is no chance for infection. Whereas if you use an absorbable material, that is you don't remove the suture, like Vicryl, like a lot of materials are there, absorbable materials. So catgut, Vicryl, all are there. If you place those materials, they will undergo absorption later, but it will take time. Some of the materials can even take 1 month to get resorbed or absorbed. So till the time, the patients will keep feeling it with the tongue, which is irritating actually. And also the suture thread will act as a nidus for food collection around it. So it's actually not a very good material of choice. I use absorbable sutures only when the patient cannot come back to you for suture removal in 1 week or 10 days. Then we don't have a choice, we have to go for absorbable sutures. So patients coming from US returning back after 5 days or 6 days, then we have no option. They won't come back for suture removal, we have to use Vicryl only. So one common doubt is where to start the suture and how many sutures. So general dictum is to start the suture from the anterior most point of the wound. If I have made an envelope incision like this, I will suture this starting point first, then immediately distal to the second molar, then I will go behind. And regarding how many sutures, there is no fixed rule that there should be 2 sutures, there should be 3, there should be 4. It is actually determined by the length of the distal incision. For example, you see in this picture, this is the distal incision. We have made first incision is here, first suturing is here, second suture is here, close to the second molar. From here, we have to make sutures every 3 millimeters. Okay, so from here 3 millimeter another suture, 3 millimeter another suture. If there is still more incision left out, another 3 millimeter, one more suture should be done. So if I have made a smaller or a shorter flap, if the tooth is very simple, I will require only 1, 2, 3 sutures. If the tooth is horizontal, then I have to remove bone here up to this level. Then I would have made a longer incision. So I will require more incisions. 1, 2, 3, 4, or even 5. It doesn't matter because the incision is going to heal across, not lengthwise. So how many ever sutures you make, remember the wound is going to heal in 7 to 10 days time. So number of sutures does not matter, but every patient is very curious. They will ask you how many sutures you have done for me. So they will get frightened if you say 5 or 6 sutures, but you tell them like enough number of sutures are made to make the wound heal within a week's time. That's all. If they're very particular, you can tell I have made 4 or 5. It's not a problem. The number of sutures, it does not matter. Post-op instructions, often a neglected part after wisdom tooth surgery, is very, very important. I give a lot of emphasis on post-operative instructions because they have to strictly follow the instructions. Otherwise, there will be a lot of pain and swelling. There is a lot of risk of infection involved if the patient is not compliant with post-op instructions. So medications, as I told you, give antibiotic. Actually, if you are using very sterile instruments, you actually don't have to give antibiotics, but in our scenario, patients, we don't trust them. They don't brush, they don't gargle with saline, or they don't gargle with mouthwash. So I generally recommend systemic antibiotics of your choice. So like we always prefer to use augmentin as antibiotic of choice. That is good enough. Sometimes if it is a tooth where previously existed inflammation was there, then you can also combine with metronidazole. If it is a deep-seated long duration, then metronidazole can be combined. Otherwise, augmentin will do, not a problem. Then along with it, in anti-inflammatory agents, it can be either steroid or your non-steroidal anti-inflammatory agents like Brufen, diclofenac, or aceclofenac. Now everybody has shifted to aceclofenacs because the dosage convenience is there. Patient has to take it only twice a day. If it is diclofenac, he'll have to take 3 times a day. So people have started preferring combination medicine like aceclo and paracetamol, like Zerodol P, ISBO-P, or so many brands are there. So 2 times a day. Adequate medication indicates antibiotic and anti-inflammatory drug. Sometimes you can also prescribe the anxiolytic agents like alprazolam or even Valium in the first and second day. Patients may not sleep because of the experience, and they might experience a little pain in the night. Some patients are very pain sensitive. So identify your patients. If they are very anxious, there is no harm in giving them benzodiazepines like Valium or compose 5 or 10 milligram for 1 or 2 days, not more than that. Do not write 7, 10. It's not necessary. What is more important is your anti-inflammatory drug. It can be steroids and non-steroidal anti-inflammatory, or a combination also is good. I generally recommend them aciclovir and then prednisolone. But aciclovir will go on for 4 to 5 days, but the steroids will be stopped on the third day. Okay. Cold packs immediately. So cold pack, the moment I say, there are a lot of questions like when to give the cold pack, how many times to give, what is the duration. Cold packs can work only immediately after the surgery when the surgical edema starts settling in. So this cold pack given outside externally works immediately. So in my practice, I make a cold pack from the fridge and give it to the patient immediately after the procedure. We tell them to apply immediately after the procedure, which is very, very effective. And the duration I recommend is half an hour, not more than that. That's more than enough. And also, you should instruct the patient not to keep it for a longer time, because the ice pack kept for a longer time will actually cause, what is the rationale behind using a cold pack? It causes a vasoconstriction because of the chillness. Okay, so when there is vasoconstriction, there is less inflammatory fluid escaping out of the vessel. That is the idea behind telling the patient to use a cold pack. But if you allow the cold pack to be there for a long time continuously, there can be a rebound vasodilation. So more inflammatory fluid is going to enter the surgical and perisurgical site, leading to more edema. So tell them to use it intermittently. ask them to give it for 10 seconds in one place and move it to another place, adjacent place, keep it for again 10 to 15 seconds, then you move it so that the same place does not get the cold pack continuously, leading to vasodilation, which is actually not very ideal. So immediately after the procedure, and then for half an hour, this half an hour patient keeps shifting it every 15 to 10 to 15 seconds to another place. Okay, cold pack. The way to do cold pack is this, and then advise them soft diet because already it's an operated area. There may be some hematoma, patient's mouth opening may not be okay. So advise them to have only soft diet at least for 24 hours, and then mandatorily ask them to use mouthwash. Brushing cannot be done very efficiently after your surgical procedures, so we usually supplement with a mouthwash, preferably antiseptic mouthwash. Non-alcoholic like chlorhexidine is a non-alcoholic good antiseptic mouthwash, meant very good for the oral cavity infections. So along with your medication, systemic medication, also advise an antiseptic mouthwash like chlorhexidine mouthwash. It's very good. Some people use betadine or povidone mouthwash also. That's also good. But I don't personally prefer the alcohol-based mouthwash like Listerine. There are two, three other. I shouldn't mention the brand names. There are alcohol-based mouthwashes which are available. So go through the composition of the mouthwash, and if it is alcohol-based, please try to avoid. It causes some kind of burning sensation in the mouth, especially after surgery. The patients may not feel very comfortable. So chlorhexidine or povidone iodine is the more ideal mouthwash to be used. Okay, this is some accidental finding through my slides, not necessary. Complications, yes, you have done the procedure and be prepared to face complications or manage complications. Okay, intraoperatively, you all know what are the complications that are anticipated. You can cause pain due to lack of local anesthesia. Bleeding is a possibility which can be easily controlled. You might fracture the third molar, or you might fracture the adjacent tooth while you apply more force with your straight elevator, or we can cause soft tissue injury because of your rotating instruments or by your very sharp instruments, or rarely we can also cause a bone fracture. Like I have seen patients ending up with fractured mandibles due to extraordinary pressure given to elevate the tooth. This happens very commonly in the distoangular impactions. I have treated patients. I have not caused a fracture so far, touch wood, but I have seen patients which are caused by other surgeons and general practitioners. This occurs mainly because not understanding the true scenario, thinking histoalveolar as a vertical impaction and thinking that the case is going to be easy, and attempting in the general dentistry, applying a lot of pressure. Keep applying pressure, the tooth will not get elevated. It will only move distally when it is distangular impaction. You will apply more and more pressure at one point of stage. Instead of tooth elevation, the bone fractures. So try to be very, very careful in choosing the cases. Study, do analysis properly, and then attempt the appropriate cases for you. And one other rare complication is tooth displacement. You will elevate the tooth also will get luxated from the socket, it will come out, but it will get displaced into buccal side or lingual side. Buccal side is easy to detect and retrieve, but lingually you have the pterygomandibular space, lingual space. So if it slips inside, then it is very difficult to locate them. You may have to do another X-ray, find out the tooth, and again you might seek help from the oral surgeon to retrieve the displaced tooth. The commonest displacement is into the sublingual pouch. Post-operatively, we see this regularly. Patients will be having some amount of discomfort in spite of all your medications. Then they are prone to have swelling. Of course, it's a surgery, there will be swelling. If it extends more than 3 days, then you have to suspect infection also, because the surgical edema starts subsiding after the second day. Trismus is a big possibility because there is hematoma around the muscles of mastication. So trismus is definitely a possibility, but there is a spontaneous recovery. You don't have to do anything. And wound dehiscence, very common. Patients not complying to your postoperative instructions, having goggling too vigorously, or brushing and causing mechanical injury, or food collection can lead to opening of the socket, which is known as wound dehiscence, or dry socket. When they goggles, when they do goggling or hot food, the blood clot will get dislodged, leading to dry socket. Or paresthesia, as we have been studying about the IAN relationship, paresthesia as possibility. Paresthesia can occur by injuring two nerves. Paresthesia, injury to the inferior alveolar nerve, will cause paresthesia of the lower lip on one side. Injury to the lingual nerve will cause paresthesia or altered sensation in the half of the tongue on that side. The inferior alveolar nerve paresthesia is relatively safer because there is a contained tube, the canal, in which the injured nerve can regenerate and repair. The paresthesia can recover. But if it is injury to the lingual nerve, it's very difficult to for spontaneous recovery. And we also have possibility for infection, because it's a surgery. It's always good. So I think that completes about lower third molars. I just want to brief a little bit about upper third molars. And 5 minutes, very few slides. We will just see how it is different from the lower third molars. Maxillary third molars, though it might appear simple, sometimes it becomes extremely difficult because of the access. It's not like lower third molar, which is in direct vision. Here you have to retract with a lot of retractors. Your assistant should be really good when you want to visualize the upper third molar impaction properly. And another complicating anatomical structure is the maxillary sinus. And when you are trying to elevate the upper third molar, never use couplants or straight elevators, because they deliver more force. You have to use gentle instruments like Cryos elevators only to luxate the impacted upper third molars, and try not to use the extraction forceps, because they have something called an orange seed popping effect. When you press with your forceps, the tooth, instead of coming occlusally, it can pop up cervically or apically into the maxillary sinus. So try not to use the forceps in upper molar impactions. So these are the points which will differ it from the lower third molar impactions. So access is really difficult. Now even today I find it very difficult to approach the upper third molars because of the positioning. You have to really retract. When you retract too much, the patient won't be able to open the mouth. If the patient closes the mouth, your access is gone. So it's always a difficulty. And this one, the maxillary sinus approximation, you also have a classification. We will leave it, it's not very mandatory. So this kind of situation, you can see actually the maxillary sinus, part of the tooth is already in the sinus. So if you apply force in upward direction, even a mild force will dislodge the tooth into the maxillary sinus instead of bringing it occlusally. So you can ask me now whether I can remove upper third molar or not. Yes, being a general practitioner, you can attempt and you can remove impacted upper third molars also, if it is a soft tissue impaction only, and if there is no distal bone which is visible in the X-ray. In this picture, in the radiographic picture, if you see, there is a lot of distal bone which is very difficult to be removed. If you are a general practitioner, you need some surgical expertise to remove this bone. And this picture, I already told, there is a proximity to the sinus. In this kind of scenario, please do not attempt to remove by yourself. If the tooth is almost erupted very close to the alveolus, if you think you raise the mucosa, you will be able to see the tooth. Probably those cases you will be able to do it. Okay. So I think we had plans to discuss only the wisdom tooth. In that case, we are done. It is almost 1 hour, 1.5 hours. So we'll skip the canines which are not very important to you. Dr. Manikosam, are you there?
That's really a wonderful presentation, Dr. Sureshkumar. You made our Sunday very educative and informative. And there are a few questions in the chat box. And
Right,
also
okay.
a few may want to ask some questions. Let us do the doubt clearing sessions first.
Yeah, we will definitely go through it. Explain.
Dr. Manasa, can you read the questions?
Yeah, please explain your first experience removing complete impacted tooth, Dr. Madhu Kumali Sairam Sudhir. Okay. So I already told you when I was an undergraduate, we are already in. I studied from Government Dental College, Chennai. So there is a lot of case load. So during undergraduation itself, you are made to assist impaction cases. So our postgraduates will be doing and will be assisting. So I have a lot of exposure to the impaction, and the teachers at the time were very kind enough to allot cases, simple cases. So they will choose the case and give it to you if they think you can handle, like how we were speaking, whether the general dental practitioner can do or a surgeon can do. They will segregate the case. Simple cases will be given. Like that, I was given in my internship itself by one of my teachers to do a lower third molar impaction, which is a simple case. Of course, my hands were shivering because it was a surgery. So, but he was all the time, he was allotting a PG, made sure that I was comfortable. I did step by step, and the tooth removal was actually flawless. There wasn't any problem. So, my first impaction was done when I was doing an internship in my college, the government dental college. Then, of course, we started doing routinely when I was postgraduate. The problem is using chisel and mallet. That time the micrometers were not available, so we were using only the chisel and mallet. So the patients will be very uncomfortable. They'll be holding the jaw like this. So, but you have to tell them there is no option. We have to remove bone. We have only this tool to remove it. So patients are unhappy, but you have to keep explaining and do a proper. You should know how to remove. There is a technique to remove the bone using chisel and mallet. If you use it in a wrong technique, there is all chances for you to fracture the bone itself. So that's how it went on. We started with mesioangular cases, and then we progressed to more difficult. Today I do almost impactions every day. I use a micromotor, and the maximum time what I take is 20 to 30 minutes. Again, I don't want to mention that I do it fast. It is just to tell you need really some expertise to do it faster and safely. Safety is more important. Avoid complication. That's whole meaning of doing this lecture.
Dr.
So,
Suresh, can you stop sharing and come on the full screen, please?
okay,
You can
stop
just
share.
stop sharing, and it will be
Okay,
screen. Yes, please. Now it
okay.
is okay.
It's fine now.
Yeah, good.
Okay. Next chat box question is, which elevator is suitable to engage the impacted molar and how to use? For the lower third molar, of course, it is straight elevator and couplings. Okay, in the straight elevator and couplings, you have various sizes. The tip width is 2 millimeter, 3 millimeter, 5 millimeter. All are available. My general recommendation for you is to use a 3 millimeter tipped straight elevator or couplings, which is small enough to engage the point of application, and it is not very large to apply more force also. So always buy a straight elevator or couplings which will have a edge width of 3 millimeters. 2 will be too small. It gets bent very easily. So 3 millimeter edge width is actually very ideal. Good question actually. Can we give dexamethasone injection after disimpaction? Yes. Dr. Parmesh. Yes, we can give dexamethasone injection after disimpaction. As I told you, anti-inflammatory is very essential. So our general tendency is to give non-steroidal anti-inflammatory. Giving dexamethasone, it's a long-acting steroid, dexamethasone cortical steroid. So that instead of the tablet form, we can give it as an injection also. But you can't ask the patient to come every day, morning and evening, give dexamethasone. So I generally ask them to take it um, as a tablet form morning and night. That is actually enough, no problem. I use injection dexamethasone when I perform this procedure under IV sedation because there is already an IV line. Okay, it becomes very easier to give dexamethasone through the IV. IM injections are a little painful for the patient, so I don't generally give IM dexamethasone after all my impactions. I only recommend oral dexamethasone, I mean prednisolone tablets, but no harm in giving dexamethasone. I hope it answers that question. Once recall instruments. Instruments. Okay, Dr. Madhukamali Sairam Sudhir. Okay, So we are from the internship, we have been taught what is the instrument kit for impaction removal, isn't it? So generally, we arrange a tray which will go step by step. So we will have the examination instrument first kept in the tray, the mouth mirror, the probe, and the cotton tweezers. Then we are going to raise a flap. So we need a BP handle and BP blade. General, we use 15 number blade. Okay, so that is the next instrument. Once I have made an incision, then I'm going to raise a flap using periosteal elevator. So two kinds of periosteal elevators are actually good. One is the moles or Ohm's periosteal elevator, what we generally use for our tooth extractions. And also especially we can use Howard's periosteal elevator, which is longer, and it can be used to protect the lingual nerve when we do the procedure. Okay, so examination instruments, then you have the BP blade and handle, then you have the periosteal elevators, the molds and Howard's periosteal elevator. After I have elevated the flap with the periosteal elevator, I have to hold the flap with a retractor. There are so many retractors available, but what we commonly use in our territory is called Austin's retractor. You are all familiar with it. So hold the flap with the Austin's elevator. So you need an Austin's elevator, which is an L-shaped retractor. So after I hold it, I need the cutting instrument. So I will have my straight handpiece and the burr ready. So that is attached to the trolley, not in the instrument tray. Make sure you autoclave the surgical burrs and then keep it ready. So after the cutting, we are going to elevate the tooth with your elevator. So next to your Austin's retractor, you should have your straight elevator or the coupe lens ready. Once it is done, you will have some artery forceps like mosquito arteries, because we are going to remove a small broken tooth piece or bone fragments. So next instrument after the straight elevator is your hemostats or the mosquito arteries. Then once it is done, then you are going to suture the flap. So next suturing instruments will come at the end of the tray, that is right hand side most end. So you will have the needle holder, then a toothed forceps or the tissue forceps, then suture cutting scissors. This is the order we arrange. And when you pick up an instrument, make sure you replace the instrument in the same place so that you don't have to look at the tray only. When you do the procedure, your hand will automatically go to that particular part. You use that instrument, it will go back to its original position. That's how at the end, beginning of the procedure, how the tray was looking, at the end of the procedure also it should look the same. But most of the times we find it like a war field, all the instruments will be clubbed together, it will look like that. But if you practice this, it will come very easily. Arrange the instruments, keep it back in the same position, it will be very neat for the patients also. It's very good to see. It's a clean, I think it'll be fine. So those are the instruments. Yeah, I don't use any more instruments, but as an extra, you can have your Cryos elevator and crossbar elevators in the tray next to the straight elevators. So this is the arrangement of instruments. What is the treatment for paresthesia complications after impacted removal? Dr. Anish Kumar. Okay, he's got too many doubts. So paresthesia, as I mentioned earlier, that is the most difficult complication to be managed. Even if it is a fracture, you do a plating, it will become all right. But paresthesia, the problem is nobody knows how severe is the injury. You all know nerve complications or the nerve injury can be in 3 degrees of severity. There can be neuropraxia, there can be neurotemesis or axonotemesis or neurotemesis. Neuropraxia is the least severe injury, followed by axonotemesis, followed by neurotemesis. So the neuropraxia is a self-healing one. If you give extended steroid therapy, it will heal. So what is to be done in paresthesia cases is continuous follow-up and evaluation once in 2 weeks. So they will come back. You have to do certain tests like touch, pressure, pain, 2-point discrimination. So you have to feel the area and then mark it in your case sheet which part is actually numb. Okay, when they come back. So generally I recommend this B12 medicines like Neurobion Forte, Reno Plus, Reno Max, all those things once daily you have to recommend. Ask the patient to come back after 2 weeks, re-evaluate the numbness. So now look at the old case sheet and see whether it is shrinking or not shrinking. As I told you, problem is assessing the severity of the, even if you take an MRI, it may not show how severe the injury is. It's only the clinical examination, clinical judgment, and then we always do medical management of the paresthesia. There is no surgical management in the first 2 to 3 months. We should never do it. So we will only recommend B12 medicines and steroids, low dose steroids. You give more steroids and then after 2 weeks you taper, like that, to keep tapering. That also is a good option. If the patient does not have improvement in 2 to 3 months, then you have to evaluate with an MRI study and then identify the amount of injury. Probably at the time you can select a surgical procedure to manage the complication, but these procedures are microscopic procedure, very difficult to do, and also the results are very unpredictable. You can, if the lingual nerve is cut, you can do reunion under the microscope, but you can never assure the patient how much is going to be the recovery. So that's very difficult to manage. So in your practice, the initial management is only medical. Remember that no surgery is advised for the first 2 to 3 months. Okay, only after the third month, the injury is going to become more permanent. Even after repair, it may not survive. So medical management is the essential part of the initial therapy. Give them B12 vitamins and steroid therapy, and then keep evaluating. That is very important, because many patients have only neuropraxia, that is only abrasion of the nerve membrane. It will heal spontaneously, it's going to be fine. And then if you don't get improvement, please refer them to a specialist, oral and maxillofacial surgeon. They will try to manage. Anish Kumar's next question is, patient coming with neck jaw pain after a month of impacted tooth removal, headache might be caused, giving suggestion warm compression. No, doctor. Warm compressions will never help after so long. Okay, your mention is after 1 month. Whether you give cold pack or cold compress or warm pack, it is only advocated in the immediate scenario, not after 1 month. If the patient is having to have some problem in the neck 1 month after the impaction, probably there should be some other cause like cervical spondylitis or musculoskeletal issues. So those patients, preferably refer them to an orthopedic doctor and then check what is the actual cause and treat accordingly. Impaction removal will never cause pain in the neck after 1 month. Chances of ecchymosis during impaction, yes, it's very high. Any surgery can cause ecchymosis and hematoma. So ecchymosis and hematoma, the difference is ecchymosis is very superficial. Just under the skin, there is deposition of blood clot. That is ecchymosis. Hematoma is collection of blood under the deep plane, like under the fat, under the muscle, above the bone, like that. So that is the difference between ecchymosis and hematoma. Ecchymosis is a high possibility. You are opening and you are severing the capillaries. The bleeding from the capillaries can accumulate under the skin, leading to ecchymosis. Even one small injection in the mental nerve can lead to ecchymosis. So it's not a bigger complication. Ecchymosis will be self-healing, or you can ask them to apply the thrombophobe gel to break down the blood clot faster and make the recovery faster. So it is not a major complication. You don't have to really worry about the ecchymosis unless if the patient is known hemophilia or any patients on blood thinner, like that. Most memorable experience during your PG. Anish. Dr. Anish is taking my autobiography or biography. Most memorable experience during your PG, what case is not actually impaction? If you ask about impaction, yes, we had a case when we did impaction. I was sectioning the tooth and the root came out. But suddenly, when I was elevating the crown, it slipped, but I could not locate the crown at all. I was exploring on the buccal side, the lingual side, in the socket, behind the socket, everywhere. The crown was not at all seen. Then I had to call help from my teachers. They also tried to palpate, but they were also not able to locate. So ultimately, what happened? They made me take an X-ray OPG, and actually, in fact, they were suggesting CT scans, but just as a preliminary examination, we took an OPG. Then we were able to see the crown shadow corresponding the middle of the ramus. That means I have pushed the crown by mistake to the pterygomandibular space, lingually and posteriorly. So luckily we continued the surgery and then we opened a larger flap. We went medial to the ramus slowly and we could not actually see the tooth crown. We were able to feel the crown with some fine instruments. We had something called a right angle forceps. With that we slowly teased it out and brought it out. That was, what should I say, interesting or very scary, I don't know. At that moment it was scary. Now it is looking interesting. Another interesting, if you ask me in general sense of oral surgery, one person was actually hit by his wife with an umbrella. Okay, so that umbrella, from the external aspect, the stick went through the cheek under the zygoma and it exited through the temporal region. Okay, so that severe was the injury. I think he must have done something very naughty. So he had that severe attack from his wife. He came with the broken stick. The stick is still there. You know what happens when there is something medial to the zygomatic arch? When the patient opens the mouth, the coronoid will not move. It is actually, there is a mechanical obstruction by the stick, so they won't be able to open the mouth. So he came, I'm not able to open the mouth. The stick is still there, I'm able to see it. Then we took a history. He was telling like I fell down from a tree and all that, but I asked how the tree can go inside like this. It was not on the floor. So then finally he agreed, this is injury caused by my wife. His wife only brought him actually. So then we convinced him for general anesthesia, because you can't just like that pull that stick out. If it starts bleeding inside, it will be a problem. So we have to open. So we posted that patient under general anesthesia, and then I opened intraorally also in the temporal region also, and slowly we retrieved that stick, and then we irrigated. Everything was okay. That was interesting. I should thank Anish for making me remember that case once again. Then Dr. Wallace Narayani. First discharge after few days of impaction, reason and solution. Okay. After, you have specifically mentioned it is after few days, isn't it? So I do that material. Okay. The patients will not have much of a pain and not much of swelling. So that is not an infection. So the basic thing is to differentiate whether it is food debris coming out in the liquefied form or it is infection and pus discharge. If it is an immediate incidence, then usually it is not infection. It is only liquefied food material. So you just have to irrigate nicely, give a pack like a dry socket, it will heal. But if there is a liquid pus discharge after few days, it is usually associated with swelling also, lymphadenopathy, everything will be there. And now it is very clear cut, it is due to infection. We need to locally debride with the saline, and then we have to start antibiotic again to cure the infection, then everything will settle down. Okay, Dr. Narmada again. Useful tips, interesting. So that's a compliment to me, there is no doubt. Thank you, Dr. Narmada. And Anish again. Anish looks very studious. TMJ recurrent dislocation patient management during impaction case. Okay. So if a TMJ dislocation patient comes to you for impaction removal, here we don't have any choice. Okay, so we have to do the impaction because it's all indicated due to some reason. It may be pericoronitis, a dental caries, or pathology. We cannot deny the treatment to him. It is only complicated by TMJ dislocation. So what you do is adequately open the mouth, keep a mouth prop, ask the patient to bite. Okay, so the mouth opening is maintained by the mouth prop, the black color rubber blocks what you have already seen in your department. Keep that on the opposite side and finish your surgery. Okay, impaction surgery. Generally this mouth prop will actually will take the loading and it will not cause excessive condylar movement, so there won't be any problem. But in case if the patient is a long-term dislocation patient, even the small amount of movement itself would have caused dislocation. So after the end of the procedure, remove the mouth block and then ask the patient to close. So normally they will close, there is no dislocation. If the patient is not able to close, then we have to understand there is dislocation. Then we have to follow the regular technique. You all know you have to keep your thumb on the lower molars, distract the condyles down, and then push it behind. That is the movement which is indicated to reduce the TMJ dislocation. Do that and send the patient. That's all. When do we need to prescribe serosopeptidase? Okay, Dr. Parmesh. Okay, yeah, good question. In the marketing, pharma marketing, they are promoting serosopeptidase, trypsin, chymotrypsin as a very effective medicines. I don't know how much it is supported by the literature, but in general we use it. So if I am dealing with the mesioangular or vertical impaction, I have just taken 10 to 15 minutes to finish. Then also we should expect some amount of surgical edema, isn't it? So there will be some minimal edema. In this kind of simple cases, I will still prefer to use only this kind of enzyme preparations. That is serosopeptidase, what is mentioned here. Another enzyme preparation is trypsin chymotrypsin combination. That also is good. Can be used for simple cases. But if I have done a very difficult deep-seated horizontal case, I would have taken more than half an hour. Then I expect more postoperative edema. In those cases, instead of enzyme preparations, I use directly the steroids and the anti-inflammatory agents. Anish Kumar again, Narayani. Yeah, okay. I think we have dealt with all the chat box thing. And Dr. Manikvasam or Dr. Manasa, anything else to be cleared?
I have one more doubt, Dr. Sureshkumar.
Yes, Manik.
Can you tell about the burr sizes for cutting the tooth as well as the bone?
Oh, okay. So I told the aerator burrs are now going to be helpful in our impaction procedure. So we have to follow the surgical burrs only. So we have 3 dimensions in surgical burrs in the tapering fissure surgical burrs. One is 701, 702, 703. These are the numbers given for these burrs. Generally, we use 703 burrs because they are adequately sized to make a appropriate guttering around the tooth. 703 burrs. When I do the tooth sectioning, okay, I can use the same 703 burr. But if I want to be very careful, if the tooth is very close to the canal, I want to use a smaller burr. I will use a 702. If I want the guttering to be less, I will use a 702 burr. 701 burr is not at all indicated for impaction cases. It's very delicate burr. It can also break when you use the burr. So 703, we can finish all the procedure. You have some companies. SS White is the commonly used company. There are other Identa burrs. So many are there. So if you are using SS White, 703 is the right size for removing impacted teeth. For smoothening the bone, of course, we have to go for a round burrs.
Is it always necessary to make a consent form? Is it performed to everyone or just be orally informed the patients?
No, oral consent is not a consent at all. Please remember, you can never defend your argument by just telling I informed the patient everything already. You may have told it, but when it becomes a legal case, if you tell that in the court of law, they will not agree. The court will accept only written consents, and written consent in the sense it should be in the general English and the patient's own language, the mother tongue. It should be in 2 languages, and it should be signed by the doctor as well as the patient. If the patient cannot sign, the patient's attender should sign it. Informed consent with signature in the proper language is the only thing that will be accepted legally.
Can you
Just
share
explain.
any such form in our group or
Yeah,
if it is there?
I can share it, no problem.
Yeah, thank you.
I'll send it in WhatsApp so that you can send it to everybody. I will send it to you soon. I actually wanted to include a small video of impaction procedure, but I expected this lecture to go on for more than 1 hour, so it will be boring to watch the video again. So probably if we have another opportunity, we can really show
definitely
the
we can
video.
have another surgical session demo also if more people will be interested to join.
I can show the video what I have done and recorded.
We'll arrange
So
it, please. Thank you
it will
so
be
much.
better. So next opportunity we can do that.
Yeah.
Yeah, excellent lecture, Dr. Suresh.
Just one more.
Dr. Narmada.
Dr. Narmada, yes, Dr. Narmada, happy to see you here. I can also see some seniors like Dr. Madhivana, who is an oral and maxillofacial surgeon, who has joined the session. Very happy. Yes, Dr. Narmada, you started speaking something.
I think lecture this much interesting, this much valuable your lecture. Collector Suresh, ரொம்ப நல்லா இருக்கு. சுரேஷ் இன்னொரு தடவை கூப்பிடுங்க. ஏன்னா ஒவ்வொரு பாயிண்ட்டும் இவ்வளோ இருக்கா, இவ்வளோ நாளா எல்லா இன்ட்ராக்ஷனும் பண்ணிட்டு இருக்கோம். பட் எல்லாமே நல்லா போகுது. பட் இவ்வளோ பாயிண்ட்ஸ் இருக்காங்கிறது வெரி யூஸ்ஃபுல் ரியலி. ஆனா நான் கரெக்டா ஆன்லைன்ல இருக்கும்போது போட்டதுனால ஆச்சு. மாணிக்கவாசகம் சார் ரொம்ப தேங்க்ஸ். இஸ் டூயிங் எக்ஸலண்ட் வே. இது எல்லாம் யூஸ்ஃபுல்லா இருக்கு தெரியுமா? திரும்ப காலேஜ் லெக்சர்
We'll
கேட்க
use him
மாதிரி
to the
இருக்கு.
maximum for our community. Don't worry, Doctor.
மாணிக்கவாசகம் you are doing excellent service
Oh,
தெரியுமா?
thank you, Doctor.
திரும்ப உட்கார்ந்து காலேஜ் லெக்சர் கேட்க மாதிரி ஒரு ஃபீலிங் இருக்கு. ஆமா,
Thank you, Doctor. அது
ஆனா
compliment.
ரொம்ப சாஃப்டா பொறுமையா புரியுற மாதிரி அமைதியா அழுத்திக்காம சுரேஷ் ரொம்ப அழகா பண்ணா. அவனை அடிக்கடி கூப்பிட்டு
Sure.
Thank
ரொம்ப
you so
நல்லா
Thank you
much.
for the kind words, Doctor.
Such a big compliment,
ஆமா.
Dr. Narmada. Thank you so much. But
ஒரே ஒரு
I think Dr.
டவுட்
Venkatesan is trying to
கேட்கணும்னு
say.
கேட்கிறேன். ஒரு டவுட் கேட்கணும்னு கேட்கிறேன். ஏதாவது சும்மா விடக்கூடாதுல்ல. இப்போ ஐம் டூயிங் ரெக்கரிங் மேக்ஸிமம் மோஸ்ட்லி நான் ஒரு செகண்ட் எடுத்துப்பேன். ஏன்னா ஐ வாஸ் ஒர்க்கிங் இன் 2 clinics இன் பிடிஎஃப்ல இல்ல. ஸோ நான் என்ன கேட்கிறேன்னா, ஸோ நான் ரிமூவ் பண்ணும்போது என்னோட சாக்கெட்டோட அளவு வந்து கொஞ்சம் கூட தெரியாது. சரியா? That socket is featured or not?
I didn't get your question properly. You want to say that you are doing impaction without raising a flap, isn't it?
Nothing. Within the second, I am removing without disturbing anything.
Okay, in that case,
So,
you will need a suture because it is almost like a normal tooth extraction. It will heal by secondary intention. You don't need sutures.
okay. 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 Thank you.
Thank you, Dr. Narmada.
Okay. Thanks.
Dr.
Thanks, Alpha.
Venki, I can see Dr. Venki. Good.
Hi, Marty, how are you?
Hi, Wendy.
Sorry,
Oh,
எனக்கு
Wendy,
full
Nice to see you.
orthodontic visit. I couldn't follow record ஆயிருக்கல. நாம வீட்ல தனியா போய் பாத்துக்கிறேன். நிறைய பாயிண்ட்ஸ் here and there தான் அங்க கலெக்ட் பண்ண முடியுது, recollect பண்ண முடியுது.
You'll get it, Dr. Venki. You'll get the whole video in YouTube as well as in WhatsApp.
Okay,
So
okay.
it will share. Yes.
மத்தியானத்துக்கு மேல பாத்துக்கிறேன். இன்னைக்கு ஆர்த்தடான்டிஸ்ட் விசிட், அதனால ஃபுல்லா ஃபாலோ பண்ண முடியல, போட்டுட்டே இருந்தேன். எனிவே இவ்வளவு நேரம் 1 hour சொன்னது 2 hours போயிருக்குனாலே ஐ நோ. அப்படி ஃபுல் எசன்ஸையும் டிஸ்டில் பண்ணி கொடுத்துட்டீங்கன்னு நினைக்கிறேன்.
நீ ரொம்ப மிஸ் பண்ணிட்ட. 2 மணி நேரம் நல்ல லெக்சர் கொடுத்தா நீ ரொம்ப லைஃப்ல மிஸ் பண்ணிட்ட. இப்போ சுற்றுலா போட்டாலும் இப்படி எல்லாம் கிடைக்காது. ஆமா.
He is doing a lot of work. Actually, he knows everything about impaction. Of course, everybody knows about it because you are all routinely doing it. I only brushed up little points. That's all. Nothing else.
Sure. Anyway, nice of you. Thanks for the knowledge transfer. நான் பார்த்துட்டு அதுக்கப்புறம் டவுட்ஸ் இருக்குன்னா கேட்கிறேன். Come back.
Anytime. And I should thank the participants who are very actively posting points to discuss. I should thank them very much. I really thank Dr. Manikavasam and Dental Veriksha for this very useful session. And I think topics like this is very, very good for dental practitioners. Like you can't keep traveling for meetings and conference. And this kind of sessions are really useful. Thank you.
Keep giving lecture monthly once. You can see MDCs in here.
So, sir, I am willing for it, provided you like my.
Yeah, Manikavasam will call you. He's doing in excellent way. Manikavasam, once again, I congratulate you. You are doing excellent service. Other 1,000 members you have reached. Almost. மக்கள் 1,000 members ஆயிட்டாங்க. Really happy for you.
Thank you, Doctor.
Thank you,
Take care. Bye-bye.
Manikavasam, thank you so much.
Over to Dr. Manasa.
I should also thank Dr. Manasa for coordinating.
It was a very informative session. Everybody just brushed up for knowledge. And basically, in the decision making, it was very helpful. Thank you for joining us today. Until the next session, seeing our messages in our community to be updated. Thank you, everyone.
Thank you so much. Thank you.
Thank you, thank you, Dr. Suresh. For the
Everybody,
time.
thank you. Have a nice Sunday. Thank you.
Thank you all for all the participants for actively participating. Thank you so much. We'll see you in the next meeting. Thank you.